Bore da, and welcome, croeso, Sarah, to our Health Visitor Celebration Day here at RCM Wales. We're really grateful for you taking the time to speak to us today, and I'm sure our audience members will be inspired by our conversation, I am sure.
I'm delighted to be here. Thank you for inviting me.
Thank you. So I've got a couple of questions for you. We have some aspiring health visitors in our audience today. Tell us about you, Sarah Cowley, the health visitor, and how your career progressed. I'm especially interested in the development of the principles of health visiting. How did they come about?
I came into health visiting in 1980, so the Principles of Health Visiting, the new book about the investigation into the principles of health visiting, was quite new at that time. It's now nearly 50 years old, and it was developed, of course, to fill a gap because they realised they had something in the curriculum saying principles of practice of health visiting, but nobody had written down what the principles were. So that was why they were developed. I worked in practice for 10 years or more. And then I was a practice teacher for a while, and I started to get a lot of questions, as you do after a while, and got very grumpy when somebody was trying to tell us to start using the nursing models that were in favour in the 1980s, none of which seemed to make sense to me in terms of health visiting, even though I'd used them previously as a nurse. And that was what started me on my research journey, because a very clever tutor who was charged with implementing this nursing model across the whole of what would now be called a trust, but was a health authority in those days, was supposed to be using the same thing. And she said to me, well, if you can't find the right model for your work, I suggest you try and develop your own. And so that started me on my research journey, which ended up doing a PhD, and I ended up at King's, where I spent the next 20 years, first as a lecturer and eventually as a professor, which was actually quite an exciting place to be, but also quite challenging as a health visitor, because it's very, very difficult to do research into health visiting because there's no funding. There was never any funding. And lots of people said, oh, you could do research into this field or that field. You could get some funding with this or funding for that. And I stuck out and did manage to get some funding, but it's always been a challenge to develop the knowledge base. So back to your principles questions, what was it you wanted to ask about that?
Just about, you talked a little bit about how they were developed and your research background. But just going back to the principles of health visiting, how well do you think they're being applied in practice today?
Well, I don't know whether they were designed to be applied in practice as such. They were designed to underpin the discussions, and it was at a period of time when actually all of research, all nursing research, and certainly health visiting research was very new. So it was about clarifying being able to explain what we did, clarifying the concepts and making sense of them. I picked up the original book, which I'm lucky to have a copy of, the investigation, and because I couldn't quite remember whether it was 77 or 79. It was 1977 when the investigation started, and it was 79 when they were published. And it was very much just a consensus operation. So it was about making sure that everybody could understand what they meant when they were using terms like health needs or facilitating, and they didn't like terms like health promotion, which were beginning to be popular because health visiting is rather gentler. It's not about trying to sell something, it's about trying to enable people to live in a way that is better for them on their terms. And I think if we look at it in that light, then health visitors today have just as much skill and ability, and possibly more than they did in the 1970s. I think the two big differences is that certainly when I first came into health visiting, then you were very much an independent practitioner and you got on with your managing your own caseload in your own way, which did allow us to do the job the way we thought it should be done. That led to some variations, but I'm not convinced that there are fewer variations now. And there are a lot of people who could be very good at the job, who are prevented from doing so, either by a rule that's made by somebody who doesn't understand health visiting, or by lack of staff, lack of time and ability. There's certainly far, far fewer health visitors in England than there were when I was in practice. And I think in Wales, you're also struggling with the numbers of staff at the moment, are you not?
Absolutely. We are, and recruitment also into the profession is an issue. And I suppose what you've just talked about, the difference, back sort of in the 80s, 90s, is very much different to how a health visitor is working today. So my next question was, how do you think health visiting has changed or evolved over the last 2 decades? Because there very much is a difference, isn't there, into delivery of the health visiting Healthy Child Wales programs, for example, compared to our core program of interventions. Perhaps when you were a health visitor, when I was a health visitor, 20 years ago when I first came in to the profession.
Yes, I mean, I think it was very much down to the individual health visitor, certainly in the 70s and 80s. And then by the 90s, it was beginning to be more of an expectation that health visitors would do as they were told. And that meant perhaps agreeing with some protocols that were produced. Might be healthy, what did you call it? Healthy Child Wales.
Healthy Child Wales program or the Healthy Child program, delivering of those core
There have
contacts.
been so many variations and all developed with good ideas and good intentions, but they don't necessarily take into account everyday practice for health visitors. And a lot of the skill of health visiting, there you can divide it into lots of pockets, one of which, of course, is that face-to-face work with an individual family, which is absolutely critical and the basis for all our work, and very much requires good relationships and building relationships. But it's also about understanding that neighbourhood that you're working in, or locality, or patch, or whatever you call it. And that means having the time to stop and chat when you see somebody on the way to the supermarket, and
Absolutely.
counting that as part of work.
Yeah.
And it means perhaps having a phone call with somebody that might be something absolutely vital that is said in that phone call. But it doesn't tick that box of saying, and did you advise them to stop smoking? But it's maybe a crucial contact about availability of some kind, perhaps having the chance to pop into a local playgroup or day nursery, particularly at collection time, so that you can see a few mums and running some groups. And all of those things need to be fitted in. So the other big chunk of skill that health visitors need is the ability to manage their caseload, to know that actually if they're at one end of the patch and the playgroup's kicking out at the other end of the patch, well, perhaps they need to go to the playgroup tomorrow and arrange their visits to the other end of the patch tomorrow. And those sorts of organisational issues can get lost in kind of well-meaning initiatives to say, oh, well, we'll give your diary to an administrator to decide your visit times, or we'll stop you doing this or that particular sort of visit and give it to a nursery nurse. That kind of connectedness gets cut across by a lot of initiatives. And it's interesting. I always like to quote Robert Dingwall, although I don't have the quote in front of me, but he likened the health visitor's work to an ethnographer's work. And, you know, whereas a public health director will have all of the stats and statistics about what's going on in an estate or a local area, a health visitor will probably be ahead of the statistics by 2 or 3 years, because they will know what's happening at that school gate or that playgroup gate. They will know when the bullying gangs move into an estate long before it appears in police crime records. And so it's about that analysis. So it's not just about knowing, it's also about analysing it, understanding what it means for the health of the families you're visiting. And the thing that we've been consistently bad at in all my decades of health visiting is conveying that knowledge up to those public health directors so that they can take them into account at the appropriate time. So that's a particular kind of needs assessment. Health visitors are the only health professionals, perhaps school nurses too, but when I trained, we did school age as well as preschool. So I include the school nurses in the health visiting bracket. It's the connection between that individual and the population. You don't have a population without an individual. So, you know, when people talk about population health and statistics, they often forget that the individual is there somewhere. Statistics of people with the tears wiped off, and we're there to see the tears as well as understand the statistics. I've lost
Absolutely.
track of where your question was
No,
leading.
it was about how health visiting has changed over the last 2 decades, and I think something else that has changed, you know, health visitors used to sit in GP surgeries. You know, that they've moved out of that environment in lots of settings now, and that's hampered perhaps those conversations that you would have walking through a waiting room. You might see one of your families. You might do an assessment of health need just in a conversation, and it is really a skill, isn't it, by health visitors who are now specialist community public health nurses, and the ability to risk assess and have that broader outlook. You described it beautifully, with an ethnographic eye. It's that observation. It's just that extra, little bit extra. Perhaps risk assessment or observation that somebody who hasn't been qualified in this field might not pick up. It's not just about being data driven, process driven. It's putting that child and family at the centre of practice, isn't it?
And the relationships, of course, are key.
Yeah,
And the
absolutely.
universality. The big worry about universality is that it's being reduced. There's this sort of hit and run practice, isn't there? You know, you go into your new birth visit with a stack of forms to be filled in, and then it goes off to somebody else in the team, and you may never see that mother again. And that actually, that's really not health visiting, because the people that are doing the follow-up have not had that health visitor training. So it's really that's a big worry. And I think we really need to become much firmer about saying what is health visiting practice and what isn't. But the big worry, of course, is always the funding. And if there's not the funding to pay people to do the work, then the work won't get done. And it's no use just ticking a box to say, well, somebody's done a visit or somebody's seen a child in a clinic. If they haven't done that health visiting assessment, they haven't been a recipient of health visiting, because
Absolutely.
that health assessment is every contact. It's continuous, and one of the interesting things about health visitors is they do treat health as though it was a process. And that's it's a very health creating outlook, because every contact also involves, well, what's going on with this person's health?
Yeah.
Is it on an upward trajectory or is it on a downward trajectory?
Mm,
Because after all, health is like lifelong, isn't it? But
absolutely.
and it requires that kind of salutogenic outlook, I think. That was something. Mean, one of the other big things that's changed. One of the positive things, but also rather curious, is that the amount of research that we have now, although still far, far, far too little about health visiting. But in the 70s and 80s, there was none. I mean, almost no research. I could number the 1980s researches on the fingers of one hand, really. So, we have absolutely mountains of research about the importance of the first 1,000 days, the first 2,000 days until the child's first 5,000 days until the child's leaving school.
Yes.
So critical for the rest of that child's life. And, it's almost, I was reflecting recently that we all know about the inverse care law, where the worse off you are, the less you get in the way of service and provision. But there seems to also be an inverse evidence law. The
Yeah.
more evidence we have about the importance of those very early foundation years, the less funding is provided to support them. And that's really sad. But we also have so much more in the way of research about what it means to create a health visitor client relationship, or health visitor parent relationship, why that matters, how much difference it makes if you're working with somebody with postnatal depression, the measurable difference that it makes. So that kind of human valuing and person-centred provision that we identified with the Why Health Visiting research, which was my last major programme of research. It was about what we called the orientation to practice, which included that health creation and salutogenesis. It also included, we called it human valuing, and the nearest theoretical base we could find to that was, of course, Carl Rogers'
Yes.
classic work about partnership working and working in a non-judgmental way with the people that you're supporting in some way. And of course, human ecology, social ecology, the way families and individuals fit into the communities they live in, which is back to what we were talking about earlier, isn't it? And that
Absolutely.
actually ran through 20 or 30 years of research about health visiting practice. And that again is something that is quite unique to health visiting in combination. Lots of people take a salutogenic approach or provide person-centered care. Nursing, learning disability nurses will tell you that they know all about person-centered care. They've written a lot about it. But it's that combination of salutogenesis and human valuing and social ecology that actually changes the mindset. You get a sort of paradigm shift from nursing to health visiting. So it's quite different, quite a challenge for new practitioners today when there's not that large cadre of experienced workers to talk these things through with, because it is about a way of being as you do whatever you're doing with people. So that's a huge change, I think.
Yeah, absolutely. I mean, I've utilised your paper, Why Health Visiting, as a lecturer and as a way of justifying the role of the health visitor within my own research projects and, my own publications, something that I would promote to the students,
Yeah.
throughout that health visitor program, because it is a very unique role. I see health business such a unique role, and that salutogenic approach, that human ecology, that human valuing is essential to the role, isn't it? Health creating.
And one of the most recent things that we did, it was published in the Journal of Health Visiting 3 or 4 years ago, I think, was we looked at all of the recommendations that came out of that whole program of research, and also the recommendations in a whole lot of that other body of research that I was talking about. So all of the evidence that underpins things like the Healthy Child Programme or the Hall Report or various NICE guidance, all sorts of official documents and various systematic reviews. And we looked at those recommendations and came up with what are effectively principles for the work environment. So it's what enables health visitors to work the way they do. And, you know, it's things like having a proportionately universal service. Universalism is really important, but it's not about giving everybody the same. Which is where you fall down when you have these protocols saying, well, you know, just health visitors just do the first visit unless there's child protection, which happens, I know, in lots of places. You need to have that nuance, and it needs to be service delivered according to need, which is proportionate universalism. It's about actually recognizing that the whole provision is relationship based. So having the service organized in a way that the relationship can build, so that you can do that, whatever is the equivalent of walking through the GP waiting room or seeing people as they come out of the daycare facility, or as well as, you know, baby clinics and drop-in clinics that people can stay in touch with the person that they want to see. And those sorts of things are really important. And the ability for health visitors to use their professional knowledge in an autonomous way is really important too. You can't be a successful health visitor if you just follow a tick list, however good that tick list is.
I suppose in preparation for speaking with you over the last couple of weeks, I've been thinking about, we seem to be constantly fighting to justify that role, the health visitor role in practice today, across policy, drivers. And if you could speak to a government on a one-to-one today, especially in relation into the investment into the role of the health visitor, especially from an early intervention and prevention perspective, what would you say to a government about health visiting?
I think I would probably try to avoid using the term unique. I use the term distinctive quite a lot. But it's also about, it's trying to convince them to see it as an investment. That providing a health visiting service is really an investment in the future of those children, and that they can see returns very quickly. So they get very good economic returns. And part of the research we now have is evidence of how many billions are saved if you reduce the burden of disease from postnatal depression, or if you increase the length of breastfeeding. And so there's short-term measurable goals which politicians need, but to see it as a return on investment, to actually recognise that it is only health visitors who are in contact with every mother and baby. We try to be in contact with the whole family, with fathers as well, but every mother and baby after that infant has been discharged from midwives until the child reaches school. And that actually that ability to support every newborn baby to grow into a healthy adult is worth investing in, and that nobody else is doing it. So, you know, I've said I resist the word unique, but it is, the combination is absolutely unique. The combination of skills and ways of working and the provision of health visiting. You can take bits out and give it to other people, but that whole combination is pretty unique. And if you get rid of health visitors, you will have to reinvent them somehow.
Wise words, Sarah. Absolutely. So we've come to the last question, really. We have some aspiring health visitors in our audience today, one of whom um, has offered her insight into the principles of health visiting. Can you offer some inspiration, positivity to all of our delegates, not just our students, but our existing health visitors who are faced with barriers and challenges into delivering the service to its fullest? You know, there's striving to deliver that health visitor agenda forward in Wales. Can you offer some hope, some inspiration for them?
Yeah, well, one of the things I spoke about when I was first arguing with these managers about imposing things that I disagreed with when I was in practice, which drove me into research. And at that time, we were talking about how health visiting was being diluted and how it was under threat and how it was in danger. Actually, health visitors have this particular ability to see things that others don't see, to be kind of on the outside a little bit, outside the mainstream of the NHS, outside the mainstream of nursing and health provision. And that always leaves them feeling exposed. But it also means that they can see more, they can see further ahead, and they can prepare for the dangers ahead and to really keep their feet on the ground with those families who will always, always value them. And it is the most exciting career that you could possibly imagine. It's the most fulfilling career, the most rewarding. So I would say to anyone thinking about it, please try it, keep going, be prepared to speak up. Remember, there's 900,000 people registered on the NMC register. There's only 20,000 of those who are health visitors. Fewer than that, I think, in practice. So we don't need to talk up for nursing. Nursing has got lots of people to speak for it. Speak for health visiting. Tell everyone how proud you are to be a health visitor, and be prepared to fight for health visiting, because it is really, really worth for both the person practicing and those families who receive good health visiting.
That is just amazing. Thank you so much for those wise words. You are an inspiration. You continue to strive to promote health visiting into your retirement. And as health visitors, we appreciate you and we appreciate the work that you've undertaken and the research that you've undertaken. So thank you so much, Diolch yn fawr, for speaking to us today. I'm sure this will generate questions in the room, and which I'll feed back to you. If there is anything, Sarah, or any points, more than happy feed those back to you. But diolch, we are really grateful, and see you soon.
Thank you, Michelle.